Thank you, Jenny. I hope I don't start coughing. I'm also have this asthma, but I don't have COVID, I promise. So I was asked today to talk about the role of transplant for myeloma, which is becoming quite controversial with the introduction of many new therapies. So what I was thinking, it took me a while to put the slides together today. I wanted, and I want to make sure that I wanted to give you a brief history of myeloma and show it to you why the transplant was introduced and then bring you to the today. So I don't know if a lot of you guys know a little bit of the history of myeloma, but it's always been fascinating to me. The first case reported in the literature was in 1845, and the patient's name was Alexander McBean. He was a young sailman from London. He was vacationing in Scotland, and he developed acute chest pain. And then he went to see this doctor, Dr. McIntyre, and really they didn't know what he had. But one of the observation that the patient made that his urine was not normal. And Dr. McIntyre listened to the patient, and he ended up to write a letter, the original letter to Dr. Burns-Jones, who was a chemist in London, asking what he thought about what the substance in the urine of this patient. And Dr. Burns-Jones became very famous, describing the substance to be the protein, which is the protein of the myeloma that is eliminated through the kidney. And we so-called Burns-Jones proteinuria. And so Dr. Burns-Jones became royal and very famous. And unfortunately, Dr. McIntyre, nobody knew about. When he published, the data was too late. But it's always our story. But very important observation and actually listening to the patient. And so from that first case reported in the literature, I want to bring you a little bit to slowly to what's happening today. The first large case in the literature in 1920, and then the first trial of treatment with myeloma was in the 1940, and I'm going to show you the results. And then the chemotherapy, the melphalan and prednisone, the first randomized clinical trials in the 60s, we became the standard of care for treatment of myeloma for many years. Melphalan and prednisone pills. Patients were taken at the beginning of each month for about 6 days, and then every month. And we'll talk about that. And then in the 70s, in the 80s, we had the explosion of what we call the conventional chemotherapy, where patient was given more cumbersome chemotherapy regime, and then the transplant in the 90s. So I'm going to bring you to that. So this is the first clinical trial of urethane with a placebo, and actually the placebo was a cola placebo. And if you see, the placebo was actually a little bit better because of the toxicity of the urethane. So this was the first published data on treatment of myeloma. And then the melphalan and prednisone, as I mentioned, became the standard of care. Now, with that combination by mouth, about 40 to 45 patients were responding. And so sometimes, they were going through cycles, and the average, unfortunately, and don't pay attention to these numbers because they're very old, the average survival of a patient with myeloma was about 3 years with this treatment, off and on. Because of that, physicians around the world started to design a different combination of chemotherapy, more cumbersome, given in the vein, with the VAD, the vincristine, adriamycin, dexamethasone, by Dr. Barloghi, become one of the most popular. And And there was a lot of enthusiasm at the beginning because more patients were responding with the melphalan and prednisone. It takes a long time before you see the response. And with this conventional chemotherapy, the responses were higher. Patients with renal and compromisation were responding. So a lot of excitement at the beginning. But unfortunately, in the 90s, at the late 90s, there were 3 large meta-analyses published in the literature, meaning people were putting all this data together and compared. And they were comparing melphalan and prednisone, so there were thousands of patients. Here is the results, 6,633 patients receiving melphalan and prednisone versus different cumbersome conventional chemotherapy. Even if the responses were higher, if you look at the survival, it was identical. Was 3 years. So it was a big disappointment because patients were receiving chemotherapy, they were having more toxicities because, as you can imagine, with the IV chemotherapy, they were having more compromisation of their immune system, infections, hospitalization, and unfortunately, big fiasco. At the end of the day, the survival was the same. So not much improvement here. 3 years conventional. So after 40 years, you saw when the melphalan was introduced in the 60s until the 90s, there was no improvement in survival. So, and this is another study that I showed the interferon, which is coming back in different shape, was also combined to the melphalan. And again, even the introduction, the combination of interferon didn't impact on the survival. So I stole these slides from one of my colleagues. The more you know about the past, the better prepared you are for the future. And I think it made absolutely sense. So I'm going to talk with you about transplant and why transplant was introduced for treatment of myeloma. So the transplant became a standard of care in the 90s. And I'm going to show you the study that led the field changing. But the high-dose melphalan was first used in 1983. McElwain and Powell's published this paper where they took, in the Lancet Oncology, they took, I believe it was around 11 patients with myeloma, and they had failed, other therapy in the melphalan and prednisone. They were trying to rescue them with the high-dose melphalan given as a bomb all at once. And and look at that, I circled that. If complete remission could be more often obtained, would survival be prolonged or its quality improved? And that is very important because at the end of the day, there is nothing magic about the high-dose melphalan. Was the fact that there was more tissue penetration, high dose, and more patients were able to achieve a complete remission and then translate it to a better outcome. And so these are some of the patients, the results are showing that all of them were responding. I think they were able to rescue 10 out of 11. And we felt in the conclusion, they felt justified to continue to treat younger patients with this approach, with the high-dose melphalan. But that was just the beginning of what's happening. This is the paper that, actually Dr. Barloghi from Little Rock, who is using transplant, and he actually introduced the stem cells rescue to rescue patients after high-dose chemotherapy, so to minimize the period of low blood count or myelosuppression. But it was not randomizing patient. It was treating everybody, was the total therapy. So it was difficult to justify, but this is the first randomized paper published in the literature from the French group, published in the New England Journal of Medicine by Dr. Attal. And this paper made history for myeloma because after 40 years of no improvement in survival, now you see the survival advantage. So you see patients, I think I have here, with the high dose living longer. And again, if you look the reason why is the number of patients achieving a complete remission compared to patients. So patients were randomized, flipping the coin to continue therapy for many months versus doing a short course of chemotherapy, the VAD, followed by transplant. And more patients were achieving a complete remission with the transplant, 22 versus 5. And that translated, we were killing more myeloma, more complete remission to a longer survival. And then after this, other publication, Dr. Child published in the early 2000s confirming the results of this study and other. And so after that, transplant from the 60s to the 90s, now you have a survival advantage. And that's the reason why in the late 90s, all the insurances started to approve transplant for patients with myeloma, younger, fit, in good performance status, older patients also in good performance status. So that's the reason why transplant was introduced in the field on the myeloma, because this data. So now we spend many years to trying to improve transplant, because unfortunately, after transplant, a lot of patients were relapsing. So how could we improve? Better induction therapy, and I will talk about the introduction of de novo agents to decrease, right? You can't do a transplant out of the gate because you need to clear the marrow first so you can collect the clean stem cells. And so if we use better induction and we bring patient to transplant with a better response, can we improve the transplant outcome? And then a lot of work on maybe changing the conditioning regimen, doing the tandem transplant, which became also very controversial. And then after sandwich the transplant with additional therapy and the maintenance, as you know, with the lenalidomide, with the Revlimid is now approved by the FDA because improves survival, prolong the life of patients with myeloma after transplant. And so, a lot of emphasis because the bottom line, the major failure of transplant was a relapse. So can we improve the transplant before, during, after? So because of that and the introduction of novel agent, now the survival of patients finally with myeloma is becoming longer and longer. When you come to see us, we're telling you, well, we're going to establish a good relationship. We're going to be together for a long time because we can control your myeloma. Why is that? Well, treatment advances, of course, and we'll talk about that, but also more sensitive diagnostic test, we better understand the disease biology, better risk stratification. We were talking this morning in a small room about the importance of recognizing that we're dealing with different diseases. And then, of course, better supportive care to keep patients ongoing with their therapy and supporting them. So what's happening? I showed you the slides up to the 90, what's happening over the last 3 decades from the beginning of 2000, 2 decades until now. Well, the introduction, explosion of the targeted therapy, more recently the immunotherapy, and then more understanding of the cytogenetic classification, the revised staging system, better test to detect myeloma earlier, and staging, and the importance of achieving the depth response, the minimal residual disease. So, and this is just a slide that I also stole from somebody else, where just showed you all the new drugs, and Sasha was talking about that have been introduced slowly over the last 2 decades. And some of us were lucky to be part of this, to see the evolution. More recently, we have the 2 CAR T-cell, the other CD38 antibody, and now more recently, the teclistamab, the first bispecific approved for this disease, and we are waiting for the talquetamab with a different target. So also, what have we learned how to treat myeloma? And this has been an evolution from the last 2 decades. We know that particularly with patients with high-risk disease, we have to eliminate the tumor, the malignant cells, very quickly before they become resistant and before they come back. And the importance of achieving a very deep response, so we're not going to be content with a partial remission anymore, where you have a 50% reduction of your clone. We want to push it down. And then, unfortunately, the continuation of therapy is clear that we need to keep suppressing the clone from coming back, and that's the reason why you see the results with the maintenance, particularly with the lenalidomide, impacting on the survival of patients with myeloma. I designed this slide, so I'm very proud of it. But just to show you, show to you what I was trying to say. So here are the patients with high risk myeloma based on genetics, and these are the patients with standard risk. So generally, the patient, not necessarily you have less myeloma, but what's happening? So with the therapy, you're trying to eliminate the clone, right? However, you have to go in depth, because if you are content with that response, these cells are going to come back very quickly. And that is the rapid progression. So some patients with high-risk myeloma, they respond faster, but they come back faster. So the bottom line, you really have to go in depth. That's the importance of achieving a fast response very quickly. But then what's going to happen is you have to sustain that. So one bird doesn't make springtime. So if you check the MRD negativity and then you say, oh, I'm safe, I'm home, is not enough, because the myeloma will come back. And the reason, and there's a lot of discussion about why is that, but the bottom line is that it's not perfect. All these tests are not perfect. And so having a sequential MRD is an indication that we eliminated the clone more in depth. And then the continuation of therapy, right? Makes sense? So with the standard risk, it takes longer to eliminate the clone, but those cells are growing slowly. And so even if you eliminate, even if you have some residual, it tends, to go away eventually with the maintenance. And you need to achieve the minimal residual disease, not necessarily in all patients, but that is opening other kinds of worms. But you have a little bit more time. So you have to be able to recognize that, the aggressiveness of the disease. Make sense? I'm very proud of this slide. So, yes. So the importance of achieving MRD negativity is becoming more and more obvious in a lot of clinical trials, not only in the newly diagnosed, but even in the CAR T cell, the bispecific patient achieving the depth of the response are doing better. And then we talk briefly about continuation of therapy with the lenalidomide versus stopping therapy. And we learned this from the very beginning, from the first trial. The continuation of therapy is becoming very important. And this is a retrospective, a pool analysis of more than 1,000 patients diagnosed with myeloma, continuing therapy versus fixed duration, again, impacting on their survival. So now, with some of the combination, we have new drugs, we see phenomenal responses. So I told you at the beginning with the melphalan and prednisone, it was about 40, 45, not many patients achieving a complete remission. With the VAD, the conventional chemotherapy, maybe a little bit better. Also, not many patients achieving a complete remission. With the transplant was better, and that's the reason why the transplant was superior. But now, with some of the combination, the lenalidomide, the bortezomib, dexamethasone, some of these responses are up to 90%. So the question is, do we need the transplant? So in the era of the new therapies, there are two major transplant studies that were conducted, both published in the New England Journal of Medicine from the French group. You recognize Dr. Attal, published in 1996, the big historical transplant. And then more recently, Paul Richardson, and we were part of that, lots of us in the United States. So I'll talk briefly about the two studies, trying to show to you, and you have to dissect the data when you read some of the study and understanding. But anyway, this is the IFM, the French study, the IFM 2009, comparing the triplet, the lenalidomide, dexa, bortezomib, followed by transplant. Here is the arm B, and then patient receive a couple of extra cycle of consolidation, and then lenalidomide for a couple of years, versus continuation of therapy in arm A. Now both patients, both groups underwent stem cells collection before they went to maintenance. And now if you look, the progression-free survival, meaning how long you remain without the disease, it was clearly with the transplant was better, right? 36 months versus 50 months. This is a longer follow-up, 90 months follow-up, again showing the survival, patient remaining off therapy longer after the transplant. So if you are a transplanter, you look that and you say, well, if you do the transplant, you're going to stay off therapy longer. Versus if you don't do the transplant, you may need to restart therapy sooner. Now, if you look at the 8 years overall survival, was not really different from the two groups. However, there is always an however, right? 75% of patients in this arm progressed to transplant at time of progression. Proceeded to transplant time of progression. So this study is comparing early transplant versus delayed transplant. And so you can argue and say, well, you can do your transplant earlier or later, and then at the end of the day, your survival is the same. And then you have to decide if you want to do it earlier and get rid of it, or later. And of course, age play an important factor, because if you are 72, 73, and you say, I'm going to do later, you're not going to get any younger, even if we try to keep it. But anyway, so it looked like the transplant was also better for patients with high risk. And so again, it became quite controversial for some of us presenting the data to you guys and say, hey, listen, if you do the transplant, you're going to stay longer, you'll freeze your myeloma, and then you can go back to the same therapy. One of the caveats here, if you decide to stay on therapy, you need to stay on therapy, because if you come off, is not a good thing, because I showed to you the myeloma will come back. So you have to be able to sustain therapy, mitigate the toxicity, and eliminate the clone. One of the data of this study that was very intriguing, and the numbers are small. So if our goal is minimal residual disease, right, the depth of the response, and you say, well, I achieved the minimal residual disease with the continuation of therapy, so why do I need to do the transplant, which is very, very reasonable question. But there are some data coming out showing the quality of MRD is important. So these are in red, the MRD negative after transplant, and these MRD negative after continuation of therapy. So the transplant MRD was probably better. Nothing magic about the Malphalan. I'm the first one to tell you there is nothing. It's just a better penetration. We eliminate the clone faster. So the clone, while you're shooting the clone every day, the residual, the clone, some of the cells will escape and develop resistance. When you throw the Malphalan, the big bomb, you have the tissue penetration, and you kill more myeloma. And we'll see that with other studies, including the stamina. I can mention the Forte trial, which is a study designed in Italy. I'm Italian, so presented also showing the quality of the MRD after the transplant. And then this is the study, we were part of it. And this study was a little bit different. So the continuation of therapy with the same triple regimen. This is determination in the US that was recently published only 1 year ago by Dr. Richardson, versus the transplant again, the 3 cycle, and then the collection of stem cells, transplant, consolidation. Now, the difference with the French study, patients in the US continue lenalidomide until progression. Well, in France, they mandated to stop the lenalidomide after 2 years. And so that's the reason why, if you look at the progression-free survival, is a little bit better even for this arm in the US, because the lenalidomide was continue longer. But then if you look at the 5 years follow-up survival, again, no difference. And actually, this study is a better study to compare transplant versus non-transplant, because it's only 20-something% of patients proceeded to transplant at time of progression. So it's a true comparison of continuation of therapy versus transplant. But the bottom line is we do have so many therapies, we can rescue patients, and that's the reason why you don't see a survival advantage. Are we going to see the survival advantage later on? And is transplant still, important? Now, we're changing even more because now we know, we were talking about earlier about induction therapy, better induction therapy. So now we don't use the triplet anymore. We are using the quadruplet. We do have a lot of publication studies showing that using 4 drugs combination, you remember the fast response? And so now we are in this situation. Now we have even better induction therapy. We do have the Cassiopeia from Italy with the VTD and the Darzalex, the Griffin, the Master trial, and in Italy. In the US, the most commonly used quadruplet is the Darzalex with the triplet that you saw before, the lenalidomide, bortezomib, dexamethasone, based on the results of this study. The Griffin study was a phase 2 randomized study where patients were randomized to receive the triplet versus the quadruplet. But the bottom line is they all proceeded to transplant. So this is not a comparison of transplant versus non-transplant. So it's difficult to extrapolate. Can we say that if you use the quadruplet and you achieve a MRD negativity, you are home free? We don't have the data. And all patients proceeded, but this study clearly showed that using the Darzalex earlier on impacted on the disease. Why? And then before I go there, there is also a second randomization. Patients were randomized after completion of transplant consolidation to receive lenalidomide alone versus lenalidomide Darzalex. And this study showed that it takes a long time, but if you look, the rate of response improved. Look at the complete remission after 2 years of maintenance with the Darzalex, with the quadruplet versus the triplet. So clearly, the depth of response, more depth of response, but all patients receive transplant here. And then you see even the MRD negativity, which was up to 64% after 2 years versus 30% with the triplet. So again, if we believe that the MRD is important and we need to chase the disease very earlier, can we use better induction therapy, right? And then now this is, the early progression-free survival showing the exposure. So we learn very quickly that exposing myeloma patients to the antibody, to the CD38, the Darzalex, or isatuximab very early is very important. So there is no doubt that is impacting on the outcome, and we do have giant studies even for the non-transplant eligible. And then just to show you just the isatuximab, because I touch base, and this is very early. I don't want to spend a lot of time talking here, but with this quadruplet with the different CD38 antibody, even after an induction, we see an enormous amount of MRD negativity. However, even the control is quite high. So, but we'll see. The data are evolving. And then this is my last slide. So there is another quadruplet that we don't know. Is carfilzomib a better proteasome inhibitor than bortezomib? And we do not have the right study to compare these two proteasome inhibitors back to back, particularly in the high risk. But a lot of us will choose one or the other in different situations. High risk, with the carfilzomib, you have less neuropathy, different type of toxicity. But this study, the reason why I wanted to show that, because Luciano Costa designed this study with what I really think is going to be the evolution for the future for myeloma. This is for patients with high risk disease. They were treated with a quadruplet and also received the transplant. And then they receive consolidation, and if you look here with the yellow stars, they are followed with MRD sequential, and then the therapy is going to be de-escalate, adjusted based on consecutive MRD negativity. And so that is going to happen. A lot of studies are going to be designed like that. There are not all patients, they're not all the same, and so some patients will need more aggressive therapy. the high risk, de-escalating the therapy only later when we really eliminated the clone. Some of the patients with the standard risk don't need probably such an aggressiveness. So we're learning about the biology of the disease. And this is just to show some of the rate of MRD negativity. 80% reach MRD negativity in this study, so very amazing. The problem is that once again the transplant was incorporated, so it's very difficult. So when you come to our clinic and we talk about transplant, we do have the data that I showed to you. We don't have data with incorporation of the quadruplet. Can the quadruplet eventually substitute the transplant? We don't know yet. Or nevertheless, the bispecific, the CAR T-cell earlier on, which we'll hope they can. And we do have a very important study earlier on comparing transplant to CAR T-cell. And I'm going to cough. And then what have we learned? The importance of achieving fast and deep responses, maintaining the MRD, again, not one time. The role of transplant, is still controversial because all of that. The importance of continuation of therapy and how to individualize therapy based on the patient history, very, very important. And I have to say, I'm sorry, but right now in 2023, despite the fact that the treatment evolution at the current time, transplant remain very important, not in magic, but it's going to be able to eliminate your clone fast and deep, and that will translate in a longer progression-free survival and hopefully, survival by the time the myeloma comes back, the initiation of a new agent. So it's freezing the myeloma. That's it.